Good afternoon. It's already 2 o'clock. Let's start. First of all, I'd like to welcome everybody. As a reminder, please mute yourself, but always show your video picture. Sign in your name, Facebook account, or email address in the chat box. Please include names of companions attending with you. Use the chat box to ask questions and make comments while the pep talk is on. There'll be group pictures at the start and at the end of the pep talk. So please show your face during the picture taking. As a reminder, also, please take the online learning cum evaluation test exercise or OLETE for mastery of learning and have a perfect score to get a certificate. I have placed the link in the Facebook page as well as the Viber group. I'd like to request Abet to post the link in the chat box. As a reminder, getting a 50 OLETE certificates will entitle one mentee to a voucher for ROJoson telemedical consultations. So let's now have a group picture taking before we start in 2 minutes. Please show your face now. Okay. Okay. One. Am I waiting for Jocelyn and Rochelle? Would you like to share your face, Rochelle and Jocelyn? Okay. And then Jocelyn. Okay, we cannot wait anymore for Jocelyn. 1, 2, 3. Okay. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the pep talk. I completed the core course on October 9 last year. From October 23, 2021 onwards, I have been tackling health disorder and health issue courses. This may take 3 years or longer. My pep talk today is entitled Fundamentals and Generalities in the medical management of thyroid cancer, part 1. This is part of the cancer course. The empowerment objective is for the lay people to have an understanding of the fundamentals and generalities in the medical management of thyroid cancer. So some definition of terms in the title and the limitation of my talk. Fundamentals to mean simplest and essential facts and theories which can serve as a basis or foundation and support for advanced information. The word generalities will be used to mean general statements of information and not covering specifics and not too detailed. Medical management mean diagnosis and treatment of thyroid cancer by physicians. So the contents of this talk, as I said, this will be part 1. Part 2 will be tackled next week. Part 1 will include screening for thyroid cancer, symptoms that will lead to suspected presence of thyroid cancer, clinical diagnosis of thyroid cancer, and paraclinical diagnostic procedures for thyroid cancer. So let's start with the first topic, screening for thyroid cancer. Screening for thyroid cancer means looking for a cancer in the thyroid gland that may be present in apparently healthy and asymptomatic persons, both males and females. There are three general screening methods, as we have been mentioning before: risk assessment, interview, or evaluation; risk assessment, interview, and physical examination. The last one is risk assessment, interview, physical examination, and with the use of instrumental or laboratory diagnostic procedures. As to the first method, which is risk assessment, interview, or evaluation, without the physical examination, without the laboratory examination, this is essentially used to look for patients with higher risk for thyroid cancer. Example will be, is there a family history of thyroid cancer? Is there a history of radiation exposure, especially during childhood? And then, is there a history of excessive exposure to chemicals? Okay. So if present, if positive for this high risk, then proceed to symptom sign evaluation or physical examination. And if indicated, do the instrumental or laboratory diagnostic procedures. If negative, during the risk assessment, interview, or evaluation, you can stop here, but better still proceed to the symptom sign evaluation, which means interview and physical examination, to complete just the basic essentials of screening. So the second method is risk assessment, interview, and physical examination this time. Okay, as I said, this constitutes the basic essentials of screening. If positive for higher risk and with suspected presence during the physical examination of signs and symptoms of cancer, proceed to instrumental or laboratory diagnostic procedures as indicated. If negative, after the interview and physical examination, okay, you can stop here. In the third method, do instrumental or laboratory diagnostic procedures only if positive for higher risk for cancer and or if with suspected presence of cancer based on the symptom and sign. So in this era of commercialism in medicine and healthcare, beware of a lot of hospitals and laboratory clinics peddling screening packages for cancer, whatever types of cancer, usually breast cancer, thyroid cancer, pancreatic cancer, etc. Don't be swayed easily by the marketing and discount offers. In the Philippines, currently, there is no official nationwide thyroid cancer screening program. My personal recommendations are the following: neck and thyroid self-examination monthly, regular, okay, starting at age 18 and onwards. And then if a mass or a lump is felt, consult a physician right away. So the starting point of a suspect for thyroid cancer is usually a mass. How to do a self-examination of the thyroid gland? Okay, this is part of the self-screening for the thyroid cancer. Okay, so stand or face a mirror, get a mirror, okay? Be ready with a glass of water to facilitate your swallowing because you have to swallow while you are examining yourself, okay? So take a sip or two of the water. Then as you swallow, okay, take a look at the neck, the movement of your neck, okay? If there's a bulge or not, okay? If there's a bulge, then there's something unusual, okay? Normally, there's no bulge. Okay? So after the inspection, do the palpation of the thyroid. Okay, so you can do this by hugging the windpipe or the trachea using one hand with one thumb on one side and then 2 to 3 fingers on the other side, and then drink some water. Then as you swallow, try to feel if there is a lump gliding between the fingers and the trachea. Okay. So on palpation, you will be able to detect enlargement. Okay. This is the normal size, and then if there is enlargement, it's bigger than the usual size. Or on palpation, you'll be able to feel some nodule, whether solitary or single or multiple. Okay, so if these nodules are present, that's a starting point for suspecting possible thyroid cancer. So symptoms that will lead to suspected presence of thyroid cancer. These are the three most common alert symptoms or symptom cues. A lump on the central part of the neck, which is the usual location of the thyroid gland, a lump on the side of the neck, and then a lump on the neck with persistent hoarseness of voice. Okay. So I will expound on these three alert symptoms later on in the section on clinical diagnosis of thyroid cancer. Clinical diagnosis means conclusion or decision made by a physician after examining a patient and after evaluation of the data on symptoms and signs. Symptoms are what are felt and observed by a patient or a person on his or her body, whereas signs are the findings of the physicians or the doctor after doing a physical examination of the patient. So procedures in clinical diagnosis of thyroid cancer or any cancer for that matter, patients presenting with symptoms as the starting point, and then the physician evaluates the symptoms to see if these are alert signals or symptom cues for cancer or not. Then after the interview or the risk assessing the symptoms, the physician does the physical examination to look for sign cues for cancer. And then after getting the symptom and sign data, the physician processes them and determine whether a cancer is present or not. Okay. So the conclusion can be, as part of the clinical diagnosis, will be not cancer, cancer suspect, cancer probable, cancer most probable. The processes used in the clinical diagnosis of cancer, pattern recognition and prevalence. Pattern recognition process means realization that the patient's presentation conforms to a previously learned picture or pattern of a disease. Prevalence process means the choice of a diagnosis is based on the frequency of occurrence of the disease in a certain locality, in a certain age and sex group, and in the affected organ or system. Remember the definition and behavior of thyroid cancer when you're looking for the pattern or recognition in the alert symptoms and sign. So remember, the thyroid cancer is a medical disease when some of the thyroid cells grow uncontrollably with the potential to invade the adjacent body tissues or organs. So if there are signs of invasion, then you suspect cancer. And the thyroid cancer also has the potential to spread to distant tissues or organs, meaning away from the neck. Okay, any organs away from the neck. If these are present or there are signs of distant spread, then you suspect thyroid cancer also. So again, these are the alert symptoms or symptom cues. A lump on the central part of the neck, okay, a lump on the side, either side, left side or right side, and then a lump on the neck with persistent hoarseness of voice. So example, this shows the normal thyroid gland, healthy thyroid gland, and then there is this nodule. Okay, the moment you have this nodule on the central part of the neck or on the thyroid gland, you start suspecting possible thyroid cancer. As I said, it could be one nodule or several nodules. Okay, with several nodules, you still continue to suspect possible cancer. But luckily, most of the time, multiple nodules have a higher risk for cancer compared to a solitary nodule. Suspect thyroid cancer if the lump or the lumps, if there are multiple, are number one, hard, inconsistency, fixed, does not move. Okay? When you try to sway it sideways or upwards and downwards, it doesn't move. Then, if this lump or lumps are accompanied by a persistent progressive hoarseness, which is a sign of invasion of the adjacent laryngeal, the nerve supplying the larynx, okay? And then, if the lump or lumps are accompanied by another lump on the side of the neck, which could be a lymph node, okay, which could be a sign of spread to the lymph node, and a distant mass suggestive of spread. The most common sites of spreads are the bones and the lungs. In the absence of cues or alert symptoms for malignancy, more likely, the lump or lumps are benign, not cancer. Fortunately, these benign tumors are more common than malignant tumors in the ratio of 90 to 10%. More common types of thyroid cancer in the Philippines, okay? Papillary thyroid carcinoma, follicular thyroid carcinoma, anaplastic carcinoma, and medullary carcinoma. These last two are not so common, okay? The most common is still your papillary thyroid cancer and follicular thyroid cancer. As to the behavior, the papillary thyroid cancer usually spread via the lymph channels or usually the presence of lymph nodes. Okay? So that's the cue for papillary thyroid cancer. Follicular thyroid cancers usually spread via the bloodstream or the blood through the blood. Okay, so they usually go to the distant areas. Okay, most common sites of metastasis or spread to distant areas are the bones and lungs for the thyroid cancer. So this patient presented with a solitary nodule or mass on the thyroid. It could either be a colloid adenomatous goiter or a cancer. The most common is papillary carcinoma, and the most common among the benign tumors are the colloid adenomatous goiter. Okay, so what will differentiate the two? You have to do more examination. When you say more examination, do more physical examination to determine, number one, the hardness or the softness of the mass, whether it's fixed or not, and then if there are lymph nodes on the side of the neck or not, or other masses in the other parts of the body. Example, this patient presented with a solitary nodule and it's hard. Okay, you can see that it's white, it's calcified. No? So you can just imagine the hardness of that mass. So if this is present, if the mass is hard, then we think of papillary carcinoma. This patient presented with a solitary nodule. So, okay, single nodule, but it's soft. Okay, so there's no cues for malignancy. So the diagnosis here is a solitary colloid adenomatous nodule or goiter. And these other patients presented with multiple nodules all over the thyroid gland with no neck nodes, with no areas of areas that will make you suspect thyroid cancer, no distant mass. The diagnosis here will be multiple colloid adenomatous goiter. Okay, so these are benign conditions. These are the most common benign conditions of the thyroid gland. A patient presented with a neck node, okay, a mass on the neck, on the side of the neck, which is usually a lymph nodes. Okay, if this is associated with a mass on the thyroid gland, then we start suspecting that this is cancer. And as we mentioned, papillary thyroid cancer usually metastasizes to the lymph nodes. So the suspect will be a papillary thyroid carcinoma. Another patient or two patients presenting with invasion of the skin overlying the thyroid mass, causing skin changes already. Okay, so as we said, cancer invades and they also spread, but the mere presence of invasion is already a cue for thyroid cancer. Okay. So this is thyroid cancer, the most common still papillary thyroid carcinoma. A patient presenting with a thyroid lump and then a distant mass in the scalp. Okay, so thyroid cancer spreads to the other areas, so you suspect cancer. Okay, and the one that is notorious for spread to the distant areas is follicular thyroid carcinoma. Okay, another patient, this is not so common. Okay, but the third cancer that's usually seen in the Philippines, okay, medullary carcinoma is very, very rare. Okay, this is usually seen in an elderly patient, usually presenting with a thyroid mass which rapidly grow in size, and then to the point of impinging or obstructing the airway. That's why this patient has a endotracheal tube in place, okay, to assist her ventilation. And then it can also compress the esophagus in that area. That's why the patient has a nasogastric tube to assist in the feeding. Now, this particular patient, a male, presenting with a mass here on initially, okay, and then on palpation, it's quite soft, okay, not hard, and then it's because of its size, it was pushing the windpipe to the other side, okay. So what was done was to do a needle aspiration because of its softness, which can imply or make you suspect that most likely there are fluids inside. So a needle aspiration was done. So what was gotten with about 100 cc of fluid. Okay. So after removal of a great amount of fluid, there's a dramatic decrease in the size of the mass. So this is colloid adenomatous nodule or a colloid cyst if there is no solid element remaining. So to repeat, procedures in the clinical diagnosis of thyroid cancer, starting point, symptoms, patient has symptoms, a thyroid lump, okay, or a neck mass, okay. The physician evaluates his symptoms to see if these are alert signals or symptom cues for cancer. The physician does the physical examination to look for the sign cues for cancer, and then the physician processes the data, symptom sign data, to determine whether a cancer is present or not. So the possible conclusion or decision will be by the doctor, by the physician, will be the complaint of the patient probably is not cancer, cancer suspect, cancer probable, cancer most probable. So there are various degrees of uncertainties here. No? Okay. So the next thing for the physician to decide is whether to do a paraclinical diagnostic procedure, okay, or what is called instrumental or laboratory diagnostic procedure. Okay. So if the physician is not quite certain what is it, okay, most likely not cancer, but still there's a suspect for cancer, then the physician can do paraclinical diagnostic procedure. So we now go to the last topic for today, paraclinical diagnostic procedure for thyroid cancer. The foremost indication for a paraclinical diagnostic procedure can be stated this way. If you are not certain on the primary clinical diagnosis and you need to be certain or be more certain before the treatment, then go for a paraclinical diagnostic procedure. So this is for both the physician as well as the patient, you, in the presence of our patient empowerment program. To decide on the indications on of the paraclinical diagnostic procedure, the physician uses two processes: the degree of certainty on the primary, the first clinical diagnosis, and comparison of the treatment plans for the first and second clinical diagnosis. As a rule, if there is no need for paraclinical diagnostic procedure, if you are quite certain of your primary clinical diagnosis, let's say 90%, 95%, 98%, okay? And there's no need if the treatment plans for the primary and secondary diagnosis are the same. If there's a need for paraclinical diagnostic procedure, the physician uses the BRCA processes. B stands for benefit, R risk, C cost, C A availability. The physician then gives and lists the options that can be done, okay, and then gives the data on the BRCA. Then, with the data given, the patient is asked what or she prefers, or the doctor can recommend. So, example of a BRCA comparative analysis will be on the first column, options 1, 2, 3. Second column, the benefit in terms of the goal is to be more definite on the diagnosis because of certain degree of uncertainty on the clinical diagnosis. So let's say the accuracy of the option 1 is 99%, 90% for option 2, and only 60% for option 3. Assuming that the risk in terms of pain, radiation, and other inconveniences are the same, acceptable. And then if the costs are 4,000 for option 1, 3,000 for option 2, and 1,000 for option 3. And again, assuming that all are available. So what will you choose? Okay, the best advice is not to choose option 3 because it has the least, it is the least accurate. Okay, 60% is not good. Okay, and then even despite the kahit na mura, okay, 1,000, okay, don't go for this one. Now, the two options left will be 1 and 2. The best still 99%, but it has a cost of 1,000. If the patient can afford 1,000 more than the 3,000, choose this one. If he cannot afford the 4,000, you can only come out with the 3,000, then you can still go for option 2 because 90% is good enough. There are several issues to discuss in the selection of paraclinical diagnostic procedures to be done for suspected cancer. So there are a lot of confusion, not to say errors happening in the Philippines, in the community. Okay. So what is not recommended is using FAD, the more popular ones, without comparative analysis in terms of benefit, risk, cost, availability of other options, usually with no considerations for the cost effectiveness and patient preference. Number 2, what is not recommended also is the shotgun approach, ordering every possible test just to catch a diagnosis. And the last one is a no-no really, is ordering tests not needed for the diagnosis of the cancer. So example of shotgun approach being done by most physicians will be combination of ultrasound, thyroid function test, all it is in one sitting right away. Okay. Or some would even include a thyroid scan. Okay. Then after the results are in, they decide on the clinical diagnosis. It should be the other way around. Decide first on the possible, most probable clinical diagnosis, and then just be guided by that in ordering for the so-called targeted and sequential prioritization approach. If you have a lump, you're not sure whether it's cancer or not, you can start with ultrasound first, and then after that, based on the ultrasound results, if indicated, you can do a needle biopsy. If the ultrasound result shows that there's no need for any other procedures anymore, then you can stop there, okay? So you don't have to order for the other tests. Okay? So the other tests are only done as indicated. Thyroid scan is the least commonly done. Okay, you only do it when you don't have any information. You don't have enough information from the ultrasound. Okay, and then if hyperthyroidism and thyroidism is being suspected, then that's the time you do the thyroid function test. What is happening in this country is that left and right thyroid function test in combination of the ultrasound. Okay, you don't have to have thyroid function test always. Okay, you can have an ultrasound without the thyroid function test if this hyperthyroidism and hypothyroidism is not being suspected. So this is just a illustration of the thyroid ultrasound. Okay, an instrument is placed on the neck, usually painless. Okay, using sound waves to detect, to study the thyroid gland and the nodules. And then needle aspiration is another type of paraclinical diagnostic procedure. Needle aspiration with or without biopsy. If the mass is solid, no, then samples can be aspirated and then put on the glass slides and then submit this for microscopic examination by a pathologist. So this is what is called biopsy. Now, if the mass is cystic, containing only fluid, no, or you don't know whether it contains fluid, then you can do the needle aspiration. And then if you get fluid, that's it. You have a colloid cyst. You have a diagnosis already right away. I will try to show you a video on this, a short video. Okay. So you can see the fluid is coming out. So the moment you see a brownish chocolate colored fluid coming out, right away, you think you should suspect already it's benign, it's colloid cyst. So this needle aspiration can be done right in the clinic, and it can give you an instant information. If you get fluid, most likely it's benign, it's a colloid cyst. Another paraclinical diagnostic procedure that was mentioned earlier is the so-called thyroid scan. The thyroid scan just tell us whether you have a cold nodule in which there's no uptake of the dye, or there's a intensive uptake of the dye, which is called hot nodule. If you have a hot nodule, then it signifies that you may have a nodule that is causing your hyperthyroidism. Okay. When you have a cold nodule, it doesn't mean, no implications whether it's malignant or benign. Example of comparative analysis of paraclinical diagnostic procedure in a patient with a dominant thyroid mass. Okay, so let's just focus on these three: ultrasound, thyroid scan, and CT scan. Okay, so comparing the three, all these three are imaging techniques, so they give indirect information compared to biopsy. Biopsy, you get a direct information because you get sample. So comparing these three indirect methods of examination, the imaging techniques. Okay, so you have 2+ for ultrasound, 1+ for thyroid scan, and then indirect the CT scan 3+. Okay. And then comparing the risk, no pain for ultrasound, no pain for thyroid scan also, but there is some radiation already being put in, the radioactive iodine. And then for the CT scan, no pain, no, but again, there's radiation. Now, in terms of cost, the CT scan is the most expensive, assuming that these are all available. So if you were to use this data for comparison and for your decision making, you would choose ultrasound as the first choice. Okay. Okay. Another table that shows comparison, but this time we put in biopsy. Okay. As I said, biopsy can give you direct information. That's why it has a 4+ diagnostic yield. Okay. So, but the only problem is that there'll be a little pain from the needle prick. Okay, so the most cost-effective diagnostic procedure for thyroid nodule, okay, as long as the patient is not afraid of the pain, then will be a biopsy, needle biopsy. Okay. CT scan is usually not the first to be done. Okay. Summary and takeaway on part 1. So I have expounded on the screening for thyroid cancer, symptoms that will lead to suspected presence of thyroid cancer, clinical diagnosis of thyroid cancer, and paraclinical diagnostic procedure for thyroid cancers. As I said, we will tackle this part 2 next week. Takeaway in relation to patient empowerment: be always in touch with reliable medical information on the fundamentals and generalities in medical management of thyroid cancer. Knowledge is power. It gives power. Use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management. So with that, I end my pep talk. Fundamentals and generalities in medical management of thyroid cancer part 1. Okay, I hope I have enlightened you to have a better understanding of the fundamentals and generalities of the medical management of thyroid cancer. So before we go to the QA, please, as a reminder, take the OLETE, okay, and have a perfect score to get a certificate. Then 50 OLETE will be equivalent, is an entitlement for a free voucher for telemedical consultation. We're now on our 31, okay, 31 lecture series. Okay, let's now have a group picture taking before we start the QA proper. Okay, all ready? Okay. 1. Sana, walang pahabol, walang habol. Meron pahabol. Ellie, Jocelyn, Deli, Beth. Yan. Para kompleto, para maganda. Jocelyn, you want like to show your face, Jocelyn? Yan. Okay, 1, 2, 3. So those who don't like to show their face, I just put them, I try to rearrange and put them on the last line. Pwede pala. Okay, the floor is now open for questions. Anything that you want to talk about? About thyroid, of course. Okay. Any questions? Radius will assist me also again this time, okay? And Beth will be a backup. Okay. Any questions? Who has a particular concern with the thyroid nodule right now? Nobody? Pwedeng free consultation ngayon. Basta thyroid, ha? Okay. It's easy to remember naman eh. We suspect thyroid cancer. If you feel a nodule, you start a little anxious, but just think positively. No? Number 1, benign thyroid nodules are still very more common at the ratio of 90 to 1. Okay. Number 2, just make sure that you don't have the cues, the alert signals of thyroid cancer. 1, the nodule is not hard. Basta malambot, okay lang, no? And then There are no neck nodes, no, and then you don't have hoarseness of voice. Yung hoarseness is not the hoarseness of COVID, not the hoarseness of a laryngitis, no. It must be present for a long time, persistent. That's why I said persistent and progressive. No, yung talagang pawala na pawala, no. Okay. So the tone of the patient, usually with hoarseness of voice, that is usually significant, they usually sound like this. Okay. So just remember those three. No?
Nagre-raise ho ng hand si Aida, Antonio.
Okay, good. Aida, good.
Good afternoon, Doc.
Good afternoon. Shoot.
Ano po, last check-up namin sa inyo ni Mrs. Taylan tsaka ni Mrs. Aragon was March 2019 bago mag-ECQ. Paano pa kaya yung gusto nila yung makapa sila mismo, yung leeg nila? Ano po yun, Doc? Nami-miss daw nila yung inyong mga lunok-lunok. Okay. Pero they're taking 200 microgram.
Okay. Of course.
Ng urothyrox.
Okay. Of course, if mas maganda yung may kumakapa, tama? Okay.
Opo.
Maganda, no? But in the light of the pandemic, no, don't take the risk, no, because there are still other way of diagnosing it, no. Okay. So one is yan nga, that's why we are teaching you, or I am, no, I don't think the other doctors are doing this. I am teaching you how to detect, how to monitor yourself, no? Okay, doing the palpation, no? Okay. So, number 2, during the telemedical consultation, nakikita ko naman, no? The only problem is that I won't be able to palpate it, but I usually ask the patient to palpate himself. But when they palpate, monitor ko rin, na how they palpate it, na kung minsan may clue ako, na may clue na ako, na. Now in case talagang may duda, then that's time we do the ultrasound already. Okay, ultrasound. So even without seeing me, they can do the ultrasound as needed. Ganon. So, kasi kung minsan may mga maliliit na nodules, kahit na magaling ako pumapa, hindi ko rin makapapa, no? Because there's a limit. No? There's a limit. No? Okay. So, usually, mga previously, the people that you mentioned, I think these are all benign colon adenoma nodule, no? Goiter, no? Okay. So, just...
may nodule lang po sila sa tabi ng tabi ng thyroid.
Yeah, okay. I cannot really remember the exact story, but I think I'm giving them as I levothyroxine, di ba? Levothyroxine. If it's levothyroxine, the assumption is that my diagnosis it's benign, no? Okay. So they just have to take it for a long time, no? So every now and then I just monitor, wag lang lalaki, no? Okay. Ganon, no?
So, pwede ko pong sabihin, Doc, na magpa-thyroid scan and then tele-consult with you?
Yeah. Okay. Again, not scan, ha? Ultrasound. Not
ultrasound po, okay.
sound, ha? Not...
And then, sa messenger na lang po for the schedule, Doc.
Yeah. No problem. No problem. Okay.
Thank you po, Doc.
Okay. Okay, Rochelle. Rochelle is raising her hands, I think.
Yes, Doc. Good afternoon po. I would just like to take this opportunity, Doc, to ask questions. Kasi I just had my annual check last December kasi required po siya sa office. Now, part po nung annual check ko yung blood test. I had the result for my FT4, TSH, and FT. Ano po ba, Doc? What does it indicate? Mataas po yung value ng TSH.
May inom ka ba ng gamot?
Hindi po. Wala pong gamot for thyroid. Doc, wala po.
Wala. Okay.
The usual medication po for my hypertension, yun lang po.
So yung ano yung mataas yung TSH
Hindi
mo?
na, hindi na tayo.
Medyo mataas po yung value niya, Doc. Yung
Yung-
TSH.
100?
Sandali. Who is talking?
Ilang?
Si Miss Aida.
Paki-mute lang. Okay. Okay. So TSH. Okay. So let's talk about interpretation of the thyroid function test. When you say thyroid function test, that include your FT4, FT3. F stands for free, no? Free thyroxine, and then free iodine, no? T3, T4. And then the TSH is thyroid stimulating hormones, no? Okay. So number one, when you do thyroid function tests, you do it when you are suspecting hypo or hyper. No? Kasi the thyroid gland produces hormones, di ba? Okay. So if it's too much, then you can have hyper. Okay, hyperthyroidism. If it's too low, no, you have hypothyroidism. Okay. So if you have symptoms of hyperthyroidism and symptoms of hypothyroidism, that's the time you take you can have the thyroid function test, no, to check, no, okay. Now, in the absence of symptoms, pina-check mo, okay, wala kang mga symptoms, di ba? Okay. So pina-check mo, okay, take note. Okay, yung mga laboratory examinations, especially yung mga blood chemistry, CBC, okay, which can vary every moment, every hour, no? Okay, and then which can also vary with the laboratory, kung minsan hindi masyadong accurate yung ano nila, no, yung mga procedure nila, no? Okay. So you have to take note of that. There could be variations, no? Okay. So then you also to check whether it's just a variation, nothing to be alarmed with. You check the values, di ba? If it's too high, no? If it's too high, let's say 3 times, 4 times higher, then that's alarming, no? That could be significant, no? Okay. And then how to go about it, basta i-analyze mo lang whether you have symptoms. Kung wala kang symptoms, then you take a look at your T3, T4 also, no? Okay, correlate mo yung T3, T4 mo with the TSH, no? If the TSH is high and then your FT4 is low, then you have hypothyroidism, no? Okay. If your TSH is low, mababa, then you have elevated, mataas yung FT4 mo, then you have hyperthyroidism, no? Okay. Now, if you have FT4, FT3 normal, but your TSH is elevated, as you mentioned, elevated, no? Okay, you have to check yung ano nga, how elevated, no? If it's kung konti lang, it could be just parang variations lang over the day, during your, kasi may mga variations going on inside your body. Kung minsan, pag ngayon magandang mood mo, pagpakuha mo ng blood, no, ganun lang yung values. Now, when you repeat it after 1 hour, 2 hours, gumanda na yung mood mo, no, magbabago na naman yung values, no? That's what I meant by mga variations in the values that will come out, no? So you really have to check, no? Okay. So a lot of times also, yung TSH, from my experience, are not as accurate as the FT4 saka T3, no? They're not as accurate, but a lot of doctors, because of brainwashing, no, they put a lot of importance on the TSH, no? Okay. But based on my experience, I've seen a lot of discrepancies sa mga TSH values. Okay. So how high is your TSH?
Little higher, Doc. Kasi nakikita ko dun sa normal values, ang pinaka ano is 4.2. But my TSH is 4.45.
Konti lang pala. Okay.
Opo.
So, okay. So, anong gusto mo? Paulit mo?
Actually, Doc, wala naman po akong symptoms. Kasi first time ko lang nagkaroon ng ganitong results. All naman the blood tests are okay. Ito lang talaga medyo abnormal. So parang gusto ko lang mag-check talaga, Doc. Just to, ma-appease lang ako. Although I do not have symptoms naman po.
Kaya nga, you have these two options. As number one, you have it checked, recheck, no? Or number two, just let it be. Observe mo na lang, then wait for, then continue to monitor your symptoms, and then wait for the next cycle of testing, diba? Okay. Ganon.
Okay, Doc.
Okay.
Thank you, Doc Joson.
So remember yung mga downside ng mga laboratory testing, ha? Maraming false alarm diyan, maraming na. If you don't need it, don't do it sa akin, ha? That's my policy. Okay. Don't rely too much on the laboratory kasi every day, every hour, any time of the day that you have it done, hindi pare-pareho ang values, iba-iba. Nagpa-fluctuate talaga, na.
Okay po. Thank you.
Any more?
Meron, Doc, question si Melingo. Is difficulty in swallowing a thyroid concern?
If there is difficulty of swallowing but there is no thyroid nodule, palagi may you have to correlate, no? Okay, kung walang thyroid nodule at kung meron man, maliit lang, then it's not, most likely it's not related, na? Okay, but if you have yung pinakita ko anaplastic carcinoma kanina ay malaki, tapos if the patient is complaining of difficulty in swallowing, yun dahil doon sa thyroid niya, na? Okay, pero kung wala kang bukol, kung meron man, maliit na maliit lang, not enough to cause difficulty in swallowing, then your difficulty swallowing is due to another cause. Okay, palagi mo ibabangga yung yung mga, kung meron kang symptoms, titingnan mo kung meron bang ibang symptoms na isasama-sama mo, no? I-combine mo to make a conclusion, no? Or you have symptoms, then you look at your physical examination, yung mga PE mo kung anong meron, no? Okay? So ibabangga mo palagi, no? Okay. Okay.
Doc, si Emily Semira is raising her hand.
Okay.
Emily.
Shoot, Emily.
Good afternoon po, Doc.
Hello
po. At may tanong lang po ako regarding sa biopsy po. Ang binabiopsy po ba is yung nodule po niya? Yung mismong nodule dun sa thyroid? O, alam mo, pag multiple nodules po yan, yun lang po bang, paano po ang biopsy niya?
Okay, so you're asking kung if there's a nodule, no?
Apo.
Or nodules, basta start
Apo.
point, kasi ang pinag-uusapan, is it cancer or not, di ba? Pag nodule.
Apo.
Okay?
Apo.
So if you want to get to know what it is, you can get a sample.
Apo.
Okay? So either one or two, depende sa decision ng doktor, no?
Apo.
If one is enough to give you the answer, isa na lang kaysa dalawang tusok, no?
Apo. Kasi okay, before po kasi meron po akong multiple nodules. Tapos binabiopsy po ako. Dito lang po yung katulad ng pinakita niyong video, doon lang po sa gitna. Pero may mga nodule ako na medyo lumaki. Yung po ba kailangan kong ipabiopsy din?
Usually, pag multiple nodules, mahirap i-biopsy lahat, di ba?
Opo.
No? So,
Opo.
it all depends on the assessment ng doktor mo.
Opo.
As I said, kung multiple nodules, ang usual basta walang cues na cancer, walang lymph nodes, no? Then
Opo.
you think of the so-called MCAG, multiple colloid adenomatous goiter, no?
Opo. Opo.
So just 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 based on the presentation lang, saka walang cues for cancer, you can be more than 90% sure na eh, di ba? More than
Opo. Opo.
so you don't have to have a biopsy, no? Actually, no.
Na-biopsy po ako as a benign thyroid nodule naman po. Sa inyo po ako nagpapa-check up. Tapos, parang lumaki lang po yung mga nodules kong iba. So, hindi ko lang po alam kung lahat po ba yun binabiopsy lahat ng nodules.
Hindi nga, di mo kaya iba. Kung minsan may 10 nodules yan, maliliit. Makikita mo sa ultrasound.
Opo.
You don't have to run after them, no? Okay.
Okay, opo.
So you can sample 1, no?
Opo.
Or at most 2, ganon.
Opo.
Okay?
Okay, sige po, Doc. Thank you po.
Okay.
Okay. Opo.
Doc, there is a question from Senaida Cabral. Doc, in my case, cystic nodule seen in ultrasound, do I need to take medicine? Maybe po bang hot compress?
Hi, Doc.
Paki-mute lang.
Paki-mute lang yung mga ano. Okay. So, pwede ba mag-hot compress? Bakit hot compress ang pinag-uusapan natin? Wag. Okay. Pag hot compress, kung masakit. Masakit ba?
Miss Senaida
Teka pa,
Cabral.
ayan. Doc, hindi naman po siya masakit.
Okay.
Kaya nasabi po nung nag-ultrasound, liquid nga daw po yung laman.
Okay nga. Hindi, ang tanong ko nga kagad sa iyo kasi gusto kong at least what do you call that? I said a lot of mukhang when you ask pwede bang hot compress, it seems that there are a lot of misunderstanding on the use of the hot compress. No? That's why I want to kasi nasa patient empowerment program tayo, no? So you use hot compress pag ano lang, pag masakit, gano'n, no? Masakit, no? Okay. Hot compress. So, kung hindi naman masakit, when you say cyst sa thyroid, saka hindi naman masakit, no? Usually benign tumor siya, no? Pag benign tumor, usually hindi masakit. Now, if it's another story, if you have meron kang abscess or infection dun sa thyroid mo, it's still possible, no? Pero bihirang-bihira yun, ganon, no? So that's the time you use the hot compress, no? Okay.
Okay.
Okay. So,
Thank you po, Doc.
so wala nang pinag-uusapan na hot or cold compress gagamitin.
Pero hindi na po kailangan, Doc. Wala po bang gamot na inumin na ano para sa nodule?
Now we will go to the second part of my answer, di ba? Okay. So, you start with diagnosis. Anong diagnosis mo ngayon? Sige nga, i-diagnose sarili mo. Benign or malignant?
Benign po.
Okay. Bakit mo sinabing benign?
Kasi wala naman po siyang sumasakit. Tas yun lang po ano yung nakapa ako. Wala naman po akong mga nodule o ano, lymph node.
May nodule siya nakita sa sa ultrasound.
Cystic nodule lang nakalagay po sa ultrasound, Doc.
Nodule na rin nga yun.
Apo.
Whether it's yung nodule is nodule. Nodule is a mass. Nodule is a lump. No? Okay. Then after that, you determine whether it's solid or cystic. Now, pag solid, walang fluid. Cystic, may fluid. Pero may nodule ka pa rin. Okay?
Apa.
Ang sabi ko kanina, starting point for suspecting thyroid cancer is a nodule, presence of nodule. Whether sa kapa mo, meron kang nakapa, or nakita sa ultrasound. Okay? Pag may nakita sa ultrasound, matatakot ka na kasi kung pa-ultrasound ka na pa-ultrasound, maraming makikita. No? Okay? Pag nakita yung reading na nodule, ayan, matatakot ka na. Di ba? Okay? Because of the possibility of cancer. No? And then, So you look at the kung wala ka naman nakakapa, you look at the description of the report, no? Kung sinabing cystic, 'di ba? Sabi ko cystic kahit nasa cystic breast mass, benign palagi, 'di ba? Okay, most of the time. So you have a benign thyroid cystic nodule, no? Which is part of the hormonal change, no? Based on the ultrasound. And then ibabangga mo sa yung katunayan sa yung findings sa leeg mo. Kung wala kang nakakapa, number 2, walang bukol sa side, no, of the neck, then most likely benign pa rin siya, no? Okay. So it's yung benign cystic nodule, it's due to hormonal changes or to some parang part of aging process sa mga tao, no, nagsisystic formation. Parang sa liver, di ba? Liver, kumisa pag nagpa-ultrasound ng liver, magkakaroon ka ng cyst, o kaya sa kidney, magkakaroon ka ng cyst because of aging process, na magkakaroon ng mga cyst, na? Okay. So, the question is ngayon, after the benign diagnosis, nandiyan ka pa ba? Nandiyan pa ba si Senny? Hindi ka na nakita. Nawala? Am I talking? Nawala si Senny? Nawala, no?
Miss Senny.
Anyway, nawala siya. Okay, anyway, for the others, no? So yung proseso is like that, no? But diagnosis first, no? Okay. So colloid cystic nodule, usually colloid benign siya, no? So the question is ngayon whether to treat or not to treat. Yan ang options palagi, di ba? Okay. So to treat or not to treat, so we have to discuss it, no? Okay. Kung maliit lang at isa lang, baka pwedeng mawala, no? I-observe mo na lang, no? Okay. Okay. Now, kung gusto mong pagamutin, para kung gusto mong sigurista ka, you want to make sure that depende sa personality mo, gusto mo talagang mga gamot-gamot, no? Okay? Then pwede mong subukan ng gamot, no? Hanggang mawala, no? Pero kung masyadong maliit lang, ang aking suggestion is just observe na lang. Okay? So remember, yung mga problema ng mga pasyente ay problem-solving decision-making, not only on the part of the doctor that you're consulting, but also on your part. Now, you have to participate in the decision-making. Okay. Yan ang tinuturo ko sa iyo, di ba? Patient empowerment program. You have to participate in the decision-making. Okay. Walang dekahon na eto, dapat ganon, eto, dapat ganon. I always give you the options. And then, I explain the pros and cons, and then we make some decisions together. Any more questions, ladies?
Meron po, Doc, from Evelyn Chu. Sabi niya, thyroid ultrasound result shows normal size thyroid gland. Diffuse parenchymal changes seen only in the right lobe. What does it mean?
Okay, if we just base it on the ultrasound, nilagay naman yan, normal size thyroid gland at walang bukol, kasi between bukol and a lump, mas importante yung bukol, diba? Okay, so no mention of a nodule, no mention of a mass, so we're not talking about thyroid cancer. Wala tayong sinususpect dito, okay. Yung diffuse parenchymal changes, meaning yung surface ng thyroid gland. Remember I show you kanina thyroid gland na yung buo, yung mas malaki, yung lumalaki, okay. So if sometimes ito kasi ultrasound ito they just put there diffuse parenchymal changes. It may not be very, very accurate. They just describe it. So don't worry about it as long as you don't have any symptoms. Okay. Seen only in the right thyroid lobe. So Number one, sige, ganun ha. To simplify things, if you have to interpret your ultrasound on your own, isipin mo lang, basta ang bukol ang pinaka-importante doon. Na? Okay? Between bukol and enlargement, bukol. No? Kasi bukol is more alarming. No? Now, kung walang bukol, diffuse changes, then you look at your symptoms. Kung merong symptoms ka ng hyperthyroidism or hypothyroidism. No? Okay. Okay. So if you have symptoms of hypothyroidism, then yung parenchymal changes na yon could be significant. No? Or if you have symptoms of hyperthyroidism like tachycardia, yung maraming mabilis ang takbo ng tibok ng puso mo, then sudden weight loss, then that's the time that you think of hyperthyroidism. Okay, so may follow-up yata si ano?
Opo, sabi niya, I have nodules but normal. TSH 13-14.
Akala ko yung ultrasound mo walang nodules. Were you able to palpate nodules? Evelyn? Evelyn? Meron kang nakakapang bukol? Kasi based on your ultrasound, walang ano. Okay. For decades, I have nodules sa ultrasound. As I said, okay. Number one, two scenarios. Either mali yung ultrasonographer mo before or talagang meron, over time, nawawala. Okay? Because of hormonal changes, because of some aging process. Gano'n, no? Parang yung kay Zenaida Cabral, maka ipaparepeat mo, maka next time, wala, hindi na makita because number one, maka mali yung readings ng radiologist mo or yung machine niya hindi siya accurate o talagang nawala na because medyo na-stabilize mo na yung ano mo, yung emotional factors mo. Kung minsan yung mga stress mo can induce some of the cystic formations, no? Okay. So kung nawawala, ganon, on and off, so ang blessing na lang yon, you don't think of cancer kasi yung cancer usually hindi siya nawawala. Okay? Okay, Evelyn and the others? Okay. So that's how you interpret all those laboratory examinations. Ibabangga mo palagi yung kapa-kaparin sa mga nararamdaman mo. Ha? Not rely completely on the laboratory exams. No? Okay? So, Lamar? Wala na?
more.
Okay. So, it's now 3:14. We'll call it the day. No? So, if you...
Dok, pwedeng magtanong after na lang kasi hindi na related sa thyroid.
Sige. Okay, but we will end this already, 3:14 already. Now, officially, we end this now. And then if you want to stay on, you can stay on and ask more questions. Now,